Good afternoon. Thank you for most of you joining me during your lunch hour. Happy to be here and chat about one of my favorite topics around dementia and how do we talk with folks about the care that they get in our healthcare system. I have adjusted my talk knowing that my colleague Dr. Hansen is speaking at the end of the session today, focusing a lot on preventive care as well. So hoping that our talks don't overlap too much together today. I have no financial disclosures to share with you all. My hope is that at the end of our time together, that you will feel comfortable classifying the things that we do for folks with dementia into primary, secondary, or tertiary prevention strategies, and that you'll feel, more importantly, like you're able to develop a personalized screening plan for each patient that you're seeing with dementia, incorporating both recommended prevention measures as well as, more importantly, what matters most to that patient in their plan. And I am going to share a case to help give an example of doing this work so that I can ground what we're talking about. So I'm going to start with the case. This is a patient that I saw several years ago, but this is very common. So 74-year-old veteran, I'm at the VA with history of hypertension, hyperlipidemia, an enlarged prostate, COPD, and coming into me with a probable diagnosis of dementia that unfortunately we confirmed or felt was the most likely diagnosis for their memory and functional deficits. Coming in to start care with me in geriatrics clinic, he and his wife came together. They've been together for 30 years. At the time of his establishing care, he is in the late early or early moderate stages of his dementia process, that he was still independent in his ADLs, but was requiring financial assistance. He was not doing driving that was very complex. So anytime that they had to come to Seattle, his wife was doing the driving and he really was just doing local driving. He'd had a few falls in the last year and was mostly furniture surfing. Felt that canes and walkers were for old people and did not want to use them. He's a former smoker, and there were no documented advanced directives or goals of care in his chart at the time he started with me. And his wife, a couple of her agenda items today were to work on scheduling his colonoscopy and getting his annual PSA test to look for prostate cancer. So we'll come back to him at the end, but this is a very common patient for me to see and probably for many of you as well. I'm going to start first with defining a few things just to make sure we're all on the same page. I think one of the important things to keep track of when you're seeing somebody is to think about the prognosis of the diseases in front of them to get a sense for whether what you're offering is going to help them during that prognostic window. A couple of tools. I like the second tool. I use that one much more. I thought the first was a very easy tool for folks to play with today if they're interested. But ePrognosis at the UCSF site is my favored tool. The first one is the quick one and is really more around actuarial tables. And you can fill in some of your data to figure out how long you have. I'm going to show an example that I filled in this patient's prognosis in here. And he was 74 at the start of things. So he had about a 75% chance of living to 83 in their kind of actuarial tables. And they felt that he would likely get to age 90. Moving into the UCSF tables, they have a lot of prognostic calculators and they're divided by where you're seeing the patient and then the goals for what you're trying to look for. And so one of the potential prognostic calculators that's available on their site is this GAGNI index, which is nice because it's targeted towards folks who are in the community like this gentleman and who are ages 65 and older. It is not specific for dementia, but you can see in the screenshot that I took from that index that dementia is one of the diagnoses that they look for in calculating what somebody's all-cause one-year mortality might be. So that's one option. In filling out the GAGNI, this gentleman is most likely going to be alive in a year, that he has only about an 8% chance of passing away in the next year. If we're looking for longer term prognosis, which in somebody like this that's pretty healthy and still community dwelling is more helpful for me, we can look at this Lee Schonborg Index, which is meant for folks that are community dwelling and older than 50, and is going to report out a 4, 5, 10, and 14-year mortality. And I think that that's more of a helpful range of information. This is not dementia specific, but it does ask questions like folks' functional status, whether they're having trouble because of either their health or their memory and managing their own money, and in doing their own bathing and showering. So there are a few things that link through. I filled out this patient's information in that, and you can see that this estimates some higher risks of mortality with longer periods of time. So that at 14 years, we're expecting that around a little higher than 80% of folks will have passed away. At 10 years, in the 60s range, and in 5 years in the 30s to 40s. And I will point out that there is now been added, they just keep adding all of these different prognostic calculators, a Deardoff prognostic calculator that looks at the risk of death in the next 10 years, specifically for folks with dementia. And in filling in this gentleman's kind of predicted time to death, that the average person between the 25th and 75th percentile with a dementia diagnosis and at his stage of dementia is around 7 years in this calculator. I want to acknowledge that prognosis is complex for everyone, and that it is influenced by so many factors that these calculators cannot take into account, especially things like socioeconomic status that are so hard to measure. But on average, we see information for folks with dementia that most are passing away between 5 and 8 years from their time of diagnosis to death, for those that are being diagnosed after 65 with dementia. And that unfortunately, folks with vascular dementia, because of their comorbidities, are likely surviving on average a shorter amount of time. And so keeping track of that limited prognosis associated with this diagnosis is really going to help us when we make recommendations clinically for other care that we're recommending in our clinic. Whoop, and apologies. So, in a recent study in Sweden, they looked at about 15,000 people and adjusted for multiple factors, including their MMSE score of folks with dementia, and looked at their time in survival. So, you can see that they're going from the very left hand corner of 0 days forward from diagnosis all the way out to 2,000 days after diagnosis. You can see that the lighter purple, the very top line, are folks with Alzheimer's disease, and the most steep drop off, the fastest time to death, is seen in the frontotemporal dementia folks, the folks with orange drop off. So I think that the summary that I would say in this study is that folks with non-Alzheimer's disease dementias often pass away faster than Alzheimer's disease dementia. And this was seen as well this is a more recent study in the United States, taking data from 41 Alzheimer's disease research centers, acknowledging that folks that get care in Alzheimer's disease research centers may not reflect everyone with dementia. However, this was more than 17,000 patients with dementia in those research centers, and showing that those folks with Lewy body dementia, so in the purple curve, this is a survival curve again, where the faster the curve drops from left to right, the faster people are passing away. And you can see that again in this curve, that folks with Alzheimer's disease type dementia have a better survival curve than other kinds of dementias. So, thinking about prognosis and that limited prognosis with these diagnoses, it's going to help us give anticipatory guidance about what that diagnosis means and how we can use the time that the person has left to focus on care that really is going to help them. And that's important for us to share that prognosis and why that impacts what we're recommending or not recommending. I think that oftentimes we shy away from talking about dementia as a terminal illness, and that it's really important that we are transparent about that because it really lets families better align the time that the person has with goals and preferences for care. And when families aren't aware that dementia can cause death, they are less likely to make decisions that are consistent with that understanding. So, another key concept other than prognosis is the idea of horizon to benefit. And that's the idea that there is a length of time that's needed for each treatment that we do to lead to a clinically meaningful risk reduction. And so, a couple of examples that I think are pretty common are that I think we all understand that if somebody's having an acute MI, that giving them antiplatelet medication like an aspirin is going to go into impact that same day, that there is benefit the very same day we give it. That often when we're prescribing something like an SSRI, however, we understand that that is going to take weeks for us to see any benefit for somebody's depression. And so being aware of how long it's going to take for each recommended intervention to impact somebody is going to help us decide whether it makes sense in a setting of a limited prognosis. Everything that I try to do, and I suspect everything all of you try to do, is within this 4Ms framework from the age-friendly health system that came from the IHI. And I throw this in here to just ground that what matters to my patient and asking that and understanding that at the top of my visits as I'm getting to know them are really going to center what I'm making recommendations for around the rest of these spaces with their mentation, their medications, and their mobility. So my last concept before we move into some other materials is the idea of prevention, which I divide in my head amongst these three buckets, with primary prevention being a goal to prevent getting a disease, like efforts to vaccinate folks. Secondary prevention is to look for diseases early in order to prevent them from getting worse. And so cancer screening is the most common example of that. And then tertiary prevention, which is a space where a lot of us are in with folks with dementia, is that we know that they have the disease and that our goal is to improve their quality of life or reduce the symptoms of diseases that they already have. And so I've given an example of cardiac rehab as a good example of that we know somebody's got heart disease and we're going to work to get them functionally improved with their heart disease so that their quality of life is better. I'm going to acknowledge that making the recommendations I'm about to recommend are challenging, as I know that you're all aware of. Our patients with dementia are often excluded from research that supports the guidelines that are making recommendation for primary, secondary, and tertiary prevention. And that many of the recommendations are relying on expert opinion. And some of them, especially as I get into the tertiary prevention space, come from my own clinical experience. So primary prevention, where we're trying to prevent folks getting diseases. I want to acknowledge that I think that in most cases, vaccinations are appropriate for folks with dementia. That if we are in a space where we're on hospice and we are not wanting to have the ramifications of kind of an acute reaction to a vaccine, then we can think about not giving vaccines. But otherwise, in folks that we think are in that 5 to 8 year range of survival, vaccines have got a lot of benefit to avoiding illness, especially as folks are high risk congregate livers towards the ends of their life, moving into nursing facilities and such. Good to prevent symptomatic burden from illness. I will acknowledge, and I suspect Dr. Hanson may talk about this more, that I have found in my elderly population that recent news about vaccinations themselves being associated with lower risks of getting dementia is one of the only current news stories that is promoting people from thinking about this kind of primary prevention type. But I wanted to acknowledge that there is thought that decreased neuroinflammation when because a lot of infections have neuroinflammation, that when you block getting an infection, that you are less likely to have that kind of inflammation in the brain, and that we may be helping to train immune systems to clear pathogens. And we're also avoiding hospitalization with vaccines, and that as we all know, hospitalization in older adults are filled with risks of things like delirium and medications that can lead to cognitive harms. And so each step that we take to keep folks out of the hospital is going to help their brain health. So just wanted to acknowledge that that's a hip item in the news today. I want to briefly acknowledge that the exercise is an excellent way to prevent many diseases from happening, that there are studies that point to exercise as one method to decrease the risk of dementia incidence. We know that it helps with mood and other comorbidities like blood pressure and heart disease that are common co-travelers with dementias. I want to acknowledge that as somebody that gets dementia progresses in their dementia, that often has concomitant apathy to doing many activities that person used to enjoy. And so, although dementia folks can benefit from maintaining function by doing exercise, um, I think that this is often a space when somebody has dementia and their caregivers are wanting them to exercise, that I say, this would be great for your person to exercise. It will work better if you as a caregiver are with this person so that you can help carry over the learning from a physical therapy session or from an exercise group. And that if we get to a place where all of the effort is towards fighting with the person with dementia around doing exercise programs, and we are leading to more caregiver burden and stress, then benefit to the patient with dementia, then we may need to reassess what we're getting from trying to force exercise. Diet is another space that we suspect strongly influences the incidence of dementia, but there is no particular current dietary cure to stop getting dementia or stopping progression of dementia once you have it. We suspect that folks that have healthy diets in Mediterranean and MIND diets, there are some observational evidence for dementia prevention. Healthy diets decrease other risk factors for chronic diseases that can influence vascular subtypes of dementia. Acknowledging that when people do get dementia, that does impact appetite, swallowing can really strongly impact cravings. I'm sure that you all here, I have a lot of patients with dementia who love sugar. That's what they want to eat. And then acknowledging something that I think is very clearly formulated now, that we, I think as a group, are agreeing that feeding tubes really are not recommended in folks with dementia to minimize aspiration or extend life, that it's not felt to be beneficial and can lead to a lot of harms. So Dr. Hansen, I believe, will spend most of her talk in that space talking in much, much, much more depth. So we're going to move on to another space of secondary prevention where we are trying to detect diseases early to prevent them from getting worse. And so I'm going to acknowledge that this is a lot of cancer screening. The idea here is that if we catch cancer early, then we can prevent harm from diseases that have progressed much more quickly. So if we catch a breast cancer early, while it's still in somebody's breast and not spread to their lymph nodes, for instance, then we can have a simple surgical correction without all of the manifestations of chemotherapy and radiation therapy. I want to acknowledge that for most people with dementia, you're going to notice a theme in these cancer screenings, where most cancer screenings need a horizon of benefit of about 10 years to see benefit from them. And so for most people with dementia that do not have a prognosis of that 10 years, likely cancer screening is not going to be beneficial. In breast cancer screening, there is no clear evidence for all comers for folks that are over 75. USPSTF has that specifically stated out. The American Cancer Society is a little bit more generous with their statement, or acknowledging that if somebody has got a life expectancy of over 10 years, there could be benefit from screening, even if they're over 75, and acknowledging that breast self-exams and clinical screening exams aren't recommended either. Prostate cancer, a little bit more tight screening guidelines, USPSTF, acknowledging that if somebody's over 70, we should no longer be screening for prostate cancer. And the American Cancer Society, again, indicating that if we have somebody that's got at least a 10-year life expectancy, which is not most patients with dementia, then we should be talking about pros and cons with them. In colon cancer, there is USPSTF is now indicating that we should screen up to 75 when folks are between 76 and 84. It should be a shared screening decision. And then if somebody's over 85, we should not be screening. And again, the Cancer Society says if you're in good health and we have a life expectancy of more than 10 years, then we should be thinking about colon cancer screening. And I'm going to emphasize to you again that most of our patients with a dementia diagnosis are not in that space, even if they are under 75. Lung cancer screening is currently recommended for folks up to age 80 who've had a 20-year PAC history of smoking and have either quit in the last 15 years or who are currently smoking. Acknowledging that data excluded people who were unlikely to be able to get lung cancer surgery or having conditions that put them at substantial risk of death in the next 8 years. And so that's going to include patients like our case study, patients with dementia were not included in the data to support this recommendation. ACS again recommending that if we're in good health and we are expecting 10 years of time, then it's okay to screen up to age 80. Cervical cancer screening, most women, if they've had a history of 3 negative tests in a row or who've had a hysterectomy, can stop cervical cancer screening at age 65. And once they stop that screening, they shouldn't start, even if they have a new sexual partner. And again, this is looking for benefits 10 years out. So in summary, I'm going to encourage you to discourage your patients. So this patient's wife who was asking about prostate cancer screening and colon cancer screening, I'm going to have a conversation in this visit about why I don't recommend getting those screenings done, because now that this person has got dementia, I'm expecting that they have got a life-limiting illness, and that the benefit that they could get from the screening is not going to be realized in their lifetime. I'm also going to acknowledge, and I fight the hardest on this around colon cancer screening, because in colon cancer screening, we're doing an invasive procedure to be able to do that screening, and we're often using anesthetic, and we are placing patients at a heightened risk of delirium and using that anesthetic. And so I'm reviewing with patients and families why, in particular, with colon cancer screening, I am not recommending proceeding with that screening. On the other hand, and if you take only one thing away from my talk today, I'd like it to be this slide. Osteoporosis screening is something that I think we do a much, much better job with women than with men, and that's because our evidence in men is less clear. But the U.S. Preventive Task Force recommends screening for osteoporosis if women are over 65. The Endocrine Society is recommending screening in men who have risk factors for bone health concerns like low body weight or a prior fracture as an adult or smoking. The horizon of benefit for osteoporosis treatment to limit risks of fractures is in the 2 to 5 year range, which is right in that range of time we expect somebody to have that has a dementia diagnosis. I'm going to remind you that much like the patient's case that I'm sharing, many, many, many patients with dementia are very high risk of falling and fracturing bones. And that, as many of you, I'm sure, have experienced in your patient care, that fracturing of bones is often leading to significant challenges with mobility afterwards, especially for these folks with dementia who have such challenge with following directions and participating with physical therapy. And so I think that one of the best things that I do for my patients with dementia that I see is to get that screening for osteoporosis to see if I can find that risk of either osteoporosis or a high FRAX score osteopenia so that I can treat that and reduce their risk of future fracture. Most of the patients I'm talking to really care about longing the time that they're at home, and avoiding fracture is one of the ways that I can support that goal for them. I do want to encourage that if you are going to start bisphosphonate therapy, that it is available via IV. That works beautifully for folks with memory concerns who may be challenged with remaining upright after oral administration of medication, but may really tolerate that IV bisphosphonate. And so this is one of the things that I don't see happening enough in primary care clinics and in geriatric clinics for our patients with dementia. And I'd really, take that away, please. Look for people's bone health and prevent fractures so that they can stay home longer. Much like cancer screening, in general, I do not recommend screening for abdominal aortic aneurysms in folks who have got dementia, that there is limited evidence of benefit in that prolonged period of time. And often these are folks who are not going to tolerate invasive surgical approaches to repair that. So in general, this is a no for me. Hearing loss screening does not have sufficient evidence in the general population. I suspect Dr. Hansen will talk later about hearing loss as a risk for dementia, and it certainly can impact folks' ability to attend and take information into their memory. Clearly impacts test performance on our cognitive screeners and is a big confounder for making a diagnosis. Want to acknowledge that in my clinic we have these pocket talkers, which I have a picture of on the device that I use very frequently. So even if somebody with dementia is not tolerating wearing hearing aids, they can often tolerate this really low-tech solution to amplify my voice and visit so that they can have a bigger role. But I think that this is a low-cost intervention to look for hearing loss, and that in folks with dementia, this can, if they're in the early stages, really improve their ability to be part of the world. In later stages, fighting with somebody who has not learned to use a hearing aid, to learn to use one, that takes a lot of cognitive reserve. And so in later stages of dementia, if we've missed the boat here, then we've missed the boat. And then I'm using pocket talkers. I want to acknowledge that talking about reducing and stopping care can be a challenging thing to do, and I'm breezing over that a bit and saying, "Oh yes, I'm going to tell this lady, this wife, that we're not going to do the things that she's asking me to do, or that I'm going to recommend that we don't do those things." Dr. Schoenberg, who I think is out in Maryland, has done a really nice qualitative research study looking at this particular space of how do we talk about limiting secondary prevention with patients. And I really appreciate that she focuses on talking about the fact that when we choose to do things, that we all have only got a certain amount of time. And that if we as physicians are focusing on cancer screenings that are not going to lead to benefit, we're going to be not focusing on other things. And so thinking about what alternative health issues we're going to prioritize when we decide to retire from cancer screening. So we aren't feeling like we're receiving less care. We're thinking that we're receiving really focused or patient, centered care that is very specific for this patient, so that we're moving away from this sense of I have a checklist and I do the same thing for everybody, no matter who they are. And instead we're saying, I am seeing you specifically with your specific list of diseases and problems, and we are sculpting that care based on those problems and based on what matters most to you. So I have found that to be very beneficial, and that most patients feel comfortable with that once we talk it through. So tertiary prevention, we know somebody has got the disease and our goal is to improve their quality of life or reduce their symptoms. And so this is where I spend the majority of my time as a physician. I'm going to acknowledge that many patients like our patient come into me with hypertension, and this has been an area that's been really a moving target in the last decade of being a clinician. that the American Heart Association has, as of last year, moved their blood pressure target to be less than 130/80 in all patients, except for if they're institutionalized or have a life expectancy less than a year. I want to acknowledge that a lot of their moving of this was influenced by the Sprint Senior trial that came out in 2016 that showed that if we target a goal of less than 120 compared to less than 140, that there are significantly better cardiovascular outcomes. I do want to acknowledge that all patients with dementia were excluded from that study. I want to say that for me, I work hard to both prevent sequela from hypertension in my patients and also avoid overtreatment in those patients with dementia, that I want to work really hard to think about what their real blood pressure is, that often with dementia, I'm seeing folks that are nervous in clinic with me and have a very high blood pressure when they're in clinic compared to their home values. So I really encourage you to collect home blood pressure values in patients with dementia before making treatment decisions. I want to acknowledge that folks with dementia are, as we've talked about, at high risk of falls, that all folks on especially diuretic medications are at risk for getting hyponatremia and acute kidney injuries. And so I'm thinking very carefully about whether somebody has got orthostatic hypotension, for instance, before I'm starting blood pressure regimens. And then I think that in these patients with dementia, many of them, their eating habits change, their mobility changes. There's a lot of muscle loss and a lot of weight loss, and that often leads to less blood pressure needs. And so to just really pay attention to weight loss in this group and pay attention to shifting blood pressure in these patients, that I'm often doing a lot of deprescribing, even to keep within these goals above that are tighter, that it's not unusual for me to see folks coming into me with blood pressures in the 100s or 110s without heart failure as a need for treating down to that kind of level. So I think it's important to think through those goals. I think many patients with dementia can handle having a blood pressure less than 130 and meeting that American Heart Association goal, but we want to think thoughtfully about that. Similarly, with diabetes management, I want to acknowledge that an A1C goal for most folks with dementia who have got moderate comorbidities and a life expectancy of less than 10 years should be in a 7.5 to 8% range. That I very frequently am seeing folks targeted to very tight blood sugar goals less than 7. And I want to encourage that I really worry about the increased risk to those patients of cardiovascular events with hypoglycemia. And that risk of hypoglycemia in this dementia population is just as dangerous as the risk of hyperglycemia, and to really think carefully if you are targeting a tighter goal than 7.5% in this group of patients. I think that so I'm going to move for the rest of this tertiary prevention into thinking about tertiary prevention specific to a dementia diagnosis, because I suspect that's what most folks listening are caring about. That one of the things I think that matters the very most when I'm first meeting somebody, if they are in a mild to moderate stage of dementia and are able to share their preferences, is to document those preferences and to make sure that I am able to understand what they want from their care, and hopefully whoever's going to be their power of attorney can understand what they want from their care while they're still able to express it. In case folks haven't seen this specific dementia directive form before, this comes out of Dr. Gaster at the University of Washington has built a dementia-specific advance directive, and there's a link to that in the slide. That allows folks to express what they would want specifically around dementia. I'm not particularly, I think that this is a lovely form. I think that if you've got a form that you're used to using in your clinic, that's fine. I think that really the main goal is to figure out who the power as attorneys are and what this person wants while they're still able to say that and to document that both for medical and legal needs. It's really important to be aware that just because somebody has dementia doesn't mean that they don't have the capacity to speak for themselves, and to acknowledge that capacity does fluctuate. That I'm sure you all have seen with sundowning, somebody that was great in the morning, not being good in the afternoon, that the complexity of the question can drive whether somebody has capacity. So to make sure that you're really thoughtful about when you are working with the patient and when you're using their powers of attorney around whether they still have capacity to answer the questions. And I think that elder law attorneys can be really helpful in working through all the legal paperwork that I feel very comfortable in my clinic doing the healthcare directives. But when we get into kind of thinking about financial powers of attorney, I'm often sending folks to elder law attorneys. This link is a resource nationally of attorneys that have got training in elder law in particular, and it allows us sort by zip code. So if folks are looking for somebody with that training, I find this to be a really helpful resource. I spend a lot of time talking about driving risk in early dementia when we've made that diagnosis, and when we're anticipating that over time that person is going to have changes in their memory and their executive function that are going to make make driving less safe. In the case that I shared, this was somebody who had already started limiting where they were driving, that this person was only driving kind of close to home and not on any highways. We really want to think about both sharing the risks of driving too long, including accidents, getting lost, harming others, um, as well as thinking about making plans for what the alternative transportation options are going to be. That often folks say, well, that's great that you think I'm unsafe to drive, doctor, but I still need to get groceries and I still need to get to my doctor's appointments. And so working with my social worker helps me a lot with doing access eligibility forms and getting folks, bus transport and transport from our VA to get around, making plans to figure out who the social circle is that can support this person, and do they have friends or family that can help get groceries, or can we set up delivery options? Um, that I am lucky to be in a really robust healthcare system where I have occupational therapy and neuropsychiatry colleagues that can help me weigh in on patient driving safety, so that I can put in consults that get more in-depth information about somebody's cognitive status and how they do in driving. If you don't happen to have that, departments of licensing also have safe driving exams, and patients can pursue that testing with the Department of Licensing, although acknowledging if they don't do well with the Department of Licensing, that is likely going to lead to their license being taken away. Um, I do a lot of handing out this Hartford Center, which is a health insurance, excuse me, a car insurance, an insurance market in general. They have got a really nice booklet called At the Crossroads that is specifically designed for folks with Alzheimer's disease and their family to guide conversation. Um, the booklet will take a family through a series of conversations to have to think ahead about when they're going to stop and what those signs are, so that they are guided in that conversation. The Alzheimer's Association is another really nice source of information about when to stop with driving, and I've got videos, examples of families talking with their loved ones about supporting that plan. Gun safety is something that I spend a lot of time talking about. I will acknowledge that being at the VA in a population where veterans have all been trained to use guns, and often it's just a high gun owning population, this comes up frequently. I'm acknowledging that I grew up in a rural area, and so as I'm talking to your GWEP, I imagine that there's a lot of rural folks as well that like to hunt and gun own. And I think it's really important to talk about that early as well. That I use this retirement lingo a lot, where I'm talking about what are we going to do with these guns? Who are we going to gift them to? How are we going to make sure that we aren't in a situation where later on in the dementia, where there's confusion in recognizing loved ones, that we don't accidentally have harm to caregivers, whether they're hired or family caregivers with gun violence. which is an unfortunate thing that I see in the news on an annual basis. So really important to just think about it ahead, make some plans, talk it through. Um, I also do a lot of thinking about if the goal is to stay at home, which for many people it is, how can we make that home a safer place to be? I am really blessed to have a really robust occupational therapy team to work with that will help me think about how to minimize fall risks in the home, how to adjust the home to make bathing and ambulating easier. That the VA has got grants to adjust doorway size or to adjust tubs to, be the kind that opens up so somebody can just step into the tub. Um, the grab bars, toilet risers. So I have a lot of equipment available to me. I hope that you're all working in health systems where at least the occupational therapist can help with some of that DME that's covered by Medicare, and getting that in the home early. I do a lot of work in later stages of dementia, thinking about wandering risk and assisting with door disguise. I've given you an example of a door disguise that has made this door look on first glance more like a piece of furniture than a door, and can confuse somebody with dementia into thinking, oh gosh, there's not actually a door here and I'm not going to try to leave. So we do a lot of thinking about sneaky ways to both lock doors so folks can't leave and also disguise doors to minimize wandering. The Alzheimer's Association has a really nice checklist of thoughts about how to make homes more safe. I do want to acknowledge that cooking injuries are a common problem, and that thinking through whether we are disabling stoves so they can't be used at all, or whether we're using safety locks over burners, things like that, that it's really important to think about these things early before they become problems that we don't really want folks to be hurt by accident or be in the hospital because they've had harm to them. So talking about these things early is important. As I already stated earlier, staying out of the hospital is really also super important for folks with dementia. That we know that there's this little bit of chicken and egg phenomenon, right? Where we go in the hospital, we get delirium, and that puts us at higher risk of getting dementia, and vice versa. If we've got dementia, that we can get delirium, and then we can see worsening of function after hospitalization. That there also is iatrogenic harm in the hospital. We see a lot of use of medications to treat dementia-associated behaviors instead of addressing them behaviorally in the way that we would hope would happen. That we often see folks not recognizing changes from a patient's baseline, or seeing dementia in the chart and assuming incorrect things about a dementia, or attributing symptoms inappropriately to dementia and missing them. So just a lot of risk in hospitalization. And so I'm doing a lot of work with the patients that I'm seeing to talk through what are the ways that they, when something comes up acutely outside of a visit, that they're going to get help, and reminding them about my e-chart and reminding them about my, the nursing triage line, just getting a lot of that work done to avoid. And then thinking through as well that one of the biggest risks to my patients meeting their goals and staying in the community is the burnout of their caregivers. That we know that dementia, because of the longevity of the disease, and because of the grief that's associated with losing the person that you know that you're caring for, there is a higher risk of burnout for dementia-associated caregivers than for patients with other medical conditions. And so the Alzheimer's Association, the Area Agency on Aging, our University of Washington has got a wonderful brain wellness clinic that has a lot of virtual content and virtual groups that I suspect even folks living outside of Washington State could take advantage of. But I do a lot of work to get folks into adult day health programs to make sure that they get respite care so that I'm supporting them staying in their home. And so back to the case that we started with, the 74-year-old who had multimorbidity, who had Alzheimer's dementia, who was having falls, who was having trouble with his finances, a former smoker, not out. He's within that 15 years of quitting, so otherwise would have been a lung cancer screening candidate. He doesn't have any advanced directives or goals of care completed, and his wife would like colonoscopy and prostate-specific antigen testing. I'm going to encourage that in this visit, I would be thinking about primary prevention. I would be recommending vaccination. I would be thinking about his and his wife's tolerance for his participation in physical therapy to work on his balance and core strength to decrease his fall risk. I would be thinking in secondary prevention about talking about why, given his prognosis with his dementia, that I feel that colon, lung, and prostate cancer are not, those screenings are not in his best interest. Instead, I'm going to encourage him to take his time to get osteoporosis screening done, given his age and falls risk, to help keep him in his home. I'm going to be thinking about his blood pressure goal to make sure that he doesn't have orthostatic hypotension, but to minimize vascular events. And if he doesn't mind taking medication, I am going to push for his blood pressure goal to be in that less than 130/80 space. And then for tertiary prevention, I'm going to work first and foremost on his goals of care, that we know that he doesn't have any of those documented right now. So that's going to be my first step, is to think about his medical and financial powers of attorney and getting those set up with him and his wife. And then after we get that settled, I'm going to next move into the spaces that I'm going to worry about next. I'm going to be thinking about, now that they've narrowed his driving some, how are we going to know when it's time to fully retire from the driving, using the Alzheimer's Association and that Hartford brochure to help me with those conversations. I'm going to be thinking about what are the ADL and IDL supports he needs. Right now, we heard just about the driving support from the wife that she was willing to do, and the financial support that she also is able to do. But as we think about maybe medication management, are we needing to get bubble packs, or are we needing to get the wife to get Medisets to help organize the medications? And I'm thinking about caregiver supports. Can I get this patient's wife in with an Alzheimer's Association group to talk about the issues that are going to be coming up? Can I get them both to, we have a group called Dementia in our community that goes and does fun things like go to the zoo and go to art museums. Can I get them a social support group of others that are going through this disease, so that they're more likely to be able to work work together and handle the ups and downs of this really challenging disease process. So in review, dementia is unfortunately a terminal illness, and on average, the prognosis from that diagnosis to death is in a 4 to 8 year range. We have hopes that in the future our treatments will prolong that, but right now that's where we are. If the horizon to benefit of a preventive therapy is longer than 4 to 8 years, it's unlikely to benefit someone with dementia. That there are some preventive care tools that have appropriate horizon to benefits, like the osteoporosis treatment that I am encouraging you to think about. And certainly providing anticipatory guidance about enhancing safety and quality of life once we have dementia. That tertiary space is a space that there is a lot that we can do when somebody has dementia to make things better for them and their family. And really at core, thinking about patient-centered care. What are the goals of this person with dementia and their family? What are they most worried about? That's going to need to remain front and center for all of our medical decision making. So with that, that is the end of my slides. I've given us some time for questions and a discussion. I look forward to the conversation.